Thank you, Viraj sir, and thank you, Sahul sir, for an excellent debate. Uh, I'm glad that you did agree that this combo is for someone, not all. And I'm going to, in next 10 minutes, show you the exact same slides what Dr. Sahu showed. And for me, this debate is about just seeing how two people can see a same data in a different way. So my job is to tell you that it is for some patients, chemotherapy for checkpoint blockade in biliary tract cancer. So we know biliary tract cancer has a very poor prognosis. This is data from SEER database that 5-year survival is virtually zero, and they don't live long. And this is the data what Dr. Sahu showed. 11.7 months is the pinnacle that we have reached with GemCis with ABC2. And we've had several attempts to better this. We've tried triplet regimens. I know AIMS, Dr. Sharma tried a FOLFIRINOX for gallbladder. We have a randomized study of FOLFIRINOX versus GemCis. It did not show any benefit, and it was published last year in JCO. While a phase 2 data of GemCis nab-paclitaxel by MD Anderson group showed median OS of 19 months. Although this is just a phase 2, we have to wait for SWOG study for a definitive answer. So the point is, we still don't have anything which beats GemCis as of now. And like Dr. Professor Chan said, that we have a lot of target-rich tumors across the board for biliary tract cancer, but they are mainly for second-line setting. And these drugs are also crazily expensive. And that means we have to do NGS for all of our patients, like the FGFR inhibitors, IDH1 inhibitors, they go for 10 lakh rupees a month today. So I don't think so. Targeting biliary tract cancer in, again, Indian setting is a smart move, and especially in the first line setting. I agree that initial results with immunotherapy were conflicting. The data of pembrolizumab and durvalumab in subsequent lines didn't show any much benefit. However, the data of nivolumab showed about a 20% response as a single agent, although some would argue that they were driven by MSI high subset. But this was the main rationale that biliary tract cancers, mainly intrahepatic cholangiocarcinoma, and for that matter, even gallbladder cancers, are slightly immunogenic, at least some form of gallbladder cancers, which I will show you that who are the ones who show hot molecular profiling, and we can exploit them with immunotherapy. So this is the Topaz 1. The best part about this study was a double-blind, multi-center global phase 3 study with overall survival. How often we see checkpoint blockades with OS as a main endpoint. And so I was glad to see this. And the important part was that in the placebo arms, full 6 months of chemotherapy was allowed. So it was not that patients got less chemotherapy. And let's see the result. They were balanced like Dr. Sahu showed. This is the same slide what Dr. Sahu showed. He wanted us to focus on the first 6 months. I agree that first 6 months there was no difference. I would not agree that they were bad. Although the pink line is below the orange lines, it was not statistically significant. But what I want to see is the last part, or the right side part, that how many of your patients are alive at 2 years. With this blockade, with this immunotherapy, at least 2 times more than 2 times people are alive if you are on durvalumab plus chemo. So we know immunotherapy, to measure the benefit of immunotherapy, we don't use medians. Even for lung cancer, the medians is at best 2 to 3 months. It's the tail of the curve, which is the selling point of any immunotherapy. And I think the long-lasting effect of immunotherapy is seen. I do agree that it is very little. So how much is little? So 1 in 8 patients. So if I were to give, like Dr. Sahu said, 6 months of therapy, that is 50 lakhs rupees for 8 people, one of them is going to go get a jackpot. So I don't know, the cost analysis is always a difficult thing because of the original molecules, but we are not here to talk about them. In a couple of years, we are going to have generics, and then this talk becomes a moot point. So this is again the same slide what Dr. Sahu showed. There were 3 times more people on treatment ongoing at the data cutoff times. So that is about, you see 20 patients on GemCis were still on treatment, while 63 patients. So that is 40 patients out of 340 were the ones who actually got the benefit. So again, if I have to see, it's 1 in 8 patient, you are more likely to have a response ongoing. This is the slide which he showed that median duration of response is 6.4 versus 6.2. As I told you, in immunotherapy, you don't look for medians, you look for those tails. And he casually ignored the upper bracket of 17.2 months, while none of the patients crossed 9 months on treatment. So our job is, I'm not here to sell durvalumab for all patients, but definitely it's our job to find out who are these 17.2 months people, who are these people who are lying on the curve, and that should be the focus of research for the next 2 to 3 years. So again, 1 in 9 patients will be on the tail if you are on durva plus chemotherapy. Something on toxicity, I'm glad that Dr. Sahu did agree that toxicity was not a problem. In fact, I would go one step further, that if you are on durva, your quality starts to improve after 6 months. As you can see, the purple line holds up while the yellow line dips. This is the reason, because the patients who were only on chemo, they were having rapid deterioration or progression of the disease, and subsequently having loss of their quality. So quality of life, overall survival, in fact, this is the classic teaching, right? That in metastatic disease, if you have one of these two, we go okay. If you have both of them, definitely it is something to consider. Now, last point, who are these patients? Who are that 1 in 8? Who is this 15% of patients who are benefiting? Apart from MSI, MSI is a no-brainer. But we had a couple of years of massive profiling of gallbladder cancer. 760 patients were profiled by Dr. Javle and MD Anderson. And what we know is that the direct DNA repair mechanism, or the HRD, is a very immunogenic tumors. And perhaps these 14 to 15% of patients are the ones which are so-called hot tumors and perhaps respond to immunotherapy. And just last month, we had a very good poster from Memorial Sloan Kettering, where they had profiled 1,000 patients of biliary tract cancer with their MSK impact. And again, the same number came out, the 17% of patients who did extremely well on immunotherapy, majority of them were HRD altered tumors, and somewhere more than TMB, more than 10. So I think it has reached NCCN. I do agree NCCN stands that it is 2B recommendation, not 2A, because our job is still not done yet. We have to find out who are these 15% of patients who would get a jackpot on immunotherapy. So I think we are not done yet, but certainly we are moving forward, and certainly something to build on. And I think so this has to be the new backbone on which we build up our further research. Thank you for your patient listening.
Thank you very much, Viraj, for bringing out the nuances of the trial. And of course, like lung cancer, the tail of the tail is always there. And 1 in 8, that is the jackpot number. How you can sift out those patients from all the patients and get the actuarial benefit from the addition of the IO. That is the million-dollar question. So before we go ahead, couple of minutes to Dr. Sahu for his rebuttal.
Yeah, 2-3 points just. First thing is that the Viraj's one slide which I just could not get through and I could not put it is the post-treatment. And there is something that is very important to always remember: who received targeted therapy and what percentage received target therapy in the Topaz post-treatment. Viraj, I hope you remember the number. It is 3 to 4% only. So, and we have been telling, the professor has been telling that 50% of these biliary tract tumors, especially cholangio, have a target. So in this target of 50%, only 3% receive is something that is the main crux. And if that would have been done in the ideal scenario, I think the results would have been equal for both the arms. That's point number one that I feel is a very important statement. Second is what I already told in the debate, that in this trial, it was skewed towards the patients of 50% being intrahepatic cholangio. And he also told, and I've been telling, that these are the patients who are very likely to respond to immune checkpoints. And in India, I feel the problem, what I have seen in my patient load, is more of the GB cancers. The cholangio is not the major problem for us. So with these small things, I feel in India, for this country where we are, and the drug is too costly, and we just cannot take out money out of science. If it has, science has to be affordable. And if that is not affordable, and if I have to spend 1 CR of rupees, Indian rupees per year for 1 month of median benefit, and mind you, the median duration of response is some in all trials where the immune checkpoint have worked well, like lung, RCC, or melanoma, it is better. It is not similar. So that is also indication. I can agree to the PFS. The PFS looks similar. The OS looks much, much better for all these tumors. So with that, I think it's an evolving field. The future for me, what I feel like would be a targeted therapy like a plus immune checkpoints. Probably that's where we are going to go in the future. Chemotherapy might be on some for someone, but those who has a target, I think that is the combination that people are going to try. VEGF inhibitors plus the immune checkpoints also are a big future targets for the biliary tract tumor. So I think that's where I end. And Talwar sir, you gave me a pretty weak topic with a single trial, which is load in favor of Viraj. But I think I learned a lot doing this debate. Thank you, sir.
See, there are two issues. One is the OS benefit. You cannot ignore it, whether it is 1 month or whether it is 1.5 months. But definitely, as Viraj said, 1 in 8, if you can nail that 1 in 8, then I think the
can I ask one question? Even the props is there. I'm not that good at statistics.
I will ask the professor.
Yeah, the CI. I just wanted about CI. The confidence interval, if you look at the upper limit, is 0.9798. Does it sound very convincing to me when I'm using especially a drug that's worth a big chunk of the money? That's one question.
So, Professor Chan, you have heard the both sides of the coin, and both of them agree and both of them disagree on certain issues, fortunately. So I would like your opinion, couple of minutes. How do you analyze this data and what is your take?
Actually, I really enjoyed the debate. I like the points raised by both our excellent doctors. Maybe I can just make some general comments. First of all, I would like to point out that the TOPAZ-1 study actually is not a very big study, only around 600 patients. So when they design, they can only address the power is only enough to address one question, which is whether the development plus chemo improve the overall survival. So this is why when you look at the pre-planned subgroup analysis, the interval is quite wide, wider actually than a lot of robust clinical trials. I agree with you that some actually the confidence interval is very wide, but this is not because the regimen spared or were not very good. I think the reason is because when you break down into subgroup analysis, the sample size is already not enough to address a no or yes question. It just gives you a hypothesis generating. So I think in the future, I think most of the biliary tract cancer doctor wait for the MSD study, which is the Pembro plus Gemcis versus Gemcis. The reason is because actually it's a more robust study. The sample size is much larger. And also second point is that they have recruited more patients which are non-Asian. So actually, I think it's really a deciding clinical trial. If this trial also shows similar hazard ratio, also show improvement of OS, I think the debate is over. It does improve the OS. But of course, the second question is who benefit more? But if this study turned out to be negative or just miss the alternative hypothesis, then there's a lot of debate. Really, maybe there's some heterogeneity as mentioned by our debater. Maybe some subgroup benefit more, some subgroup benefit less. So there's a rumor it may be released in ESMO or ASCO GI, we don't know, but the result probably will be available somehow in the next 6 months to 1 year time. Let's see. Another minor point I forgot, I would like to mention is I fully agree, we need biomarker. But if you learn from our liver cancer, which are a bit more far away, when I think the CheckMate 459, they try to analyze any predictive biomarker. If you just look at PD-L1, I can assure you, it definitely is not determining. You only see a slight difference. When they look at the more environmental factor, like the I think there's some signature in the inflammatory environment, like the interferon gamma or some of the environmental factors actually is predictive. So my belief is if you just look at tissues, probably is not robust enough to look at the environment. You need to have a set like the plasma sequencing or even the non-tumorous liver, which I think is very difficult. So I'm sure it takes long path to develop the biomarkers. This is my only 2 comments about how to interpret this trial, but I enjoy the debate a lot. Thank you for bringing me there.